I'm Dr. Mark Sue, and welcome to the Functional Medicine Reality Podcast. Join me and our community weekly as we bring you unfiltered health from inflammation to longevity. Real stories, real people, real solutions. Experience real-life health changes from both patients and practitioners, and learn how to turn cutting-edge information into real results in your own life so you can feel better, live longer, live healthier, and be confident and clear in your healthcare choices. Let's get real and get results. The one thing I've been asked many times by patients is the following: don't doctors get paid for their prescriptions, for writing prescriptions? And to that I answer, if that has happened before or happens now, I've never been aware of it. I've had a couple of patients who have worked in leadership or administration on some level, maybe coincidentally in the mental health field. And I'm talking, in this case, inpatient mental health, all right, psychiatric facilities, inpatient care, where they were of the understanding or outright awareness, reportedly, that there was something of that sort happening many years ago. All right. But I've never seen that myself in any subspecialty. And I'm not aware of how that would be an arrangement, whether between pharmaceutical companies or healthcare facilities, whether it's a hospital or other kind of care facility, and a prescribing practitioner. However, I am aware of metrics, all right, measurements that doctors and hospitals, for that matter, beyond that, I don't know. Physical therapists, rehab facility, short and long-term facilities, rehab facilities, absolutely. Okay, but physical therapists, x-ray centers, imaging centers and stuff like that, I don't know. But there are metrics that, I will just speak for the outpatient doctors, there are metrics that are asked to be met. So here's what that looks like and why that matters to you as a patient, all right? So it is illegal to have unions in America for doctors. All right. When I say doctors here, I'm going to include other prescribing practitioners. I don't care if it's an MD or a D or a nurse practitioner or a physician assistant, but I'm not including naturopaths. I can't speak for naturopaths who are prescribers in many states. And I'm excluding here chiropractors and other healthcare practitioners who are not able to prescribe medication. Okay. In America, it is illegal to have unions. However, there are these entities that I like to call pseudo unions. And I'm not being facetious. It's just, see, the insurance companies don't want to have to set up contracts with thousands, hundreds and thousands, or who knows, whatever the numbers are, millions of prescribers. Okay. They don't want to have to create a negotiating contract. They don't want to have to negotiate a contract with every single office in America. In our brick and mortar office, we're an independent office, and whichever insurance company doesn't want to have to negotiate with us just for the 5 of us in our office. If we were part of Mass General Brigham or Kaiser Permanente or whatever, pick your large healthcare group, then it's easier for any given insurance company to just come to us as a large group and say, hey, let's negotiate a contract with your 150 different outpatient office practicing doctors, right? Or to go to a huge hospital system that employs hundreds of internists, hospitalists, specialists, et cetera, ER doctors, et cetera, and just negotiate contracts with all of the lot, all at one time. There are these pseudo unions where these doctors group together and they're represented by a given legal entity that then coordinates these contracts with the insurance companies. And so everyone basically gets the same contracting, and it's just a lot easier for the insurance companies. And it's a heck of a lot easier for the doctors too. The doctors don't want to have to deal with all this stuff. But here's what happens. Over the years, let's say if the insurance company used to pay myself, let's say, I'm going to make up a number, right? For this kind of office visit for a given patient, we are reimbursing you $200, all right? But over the years, the agreement became, we're going to hold back 30% of your pay. And again, I'm making up the numbers. Could be 20%, I don't know, 15%, who knows? We're going to hold, for easy numbers, we're going to hold back 25% of your pay. All right, that $200 for all your visits across the board, not just for those visits, all visits. All right, a quarter of the reimbursement that we know from our data from the previous X number of years, we're likely to have to pay you out X amount of money over the next coming fiscal year, because we can see all our members who are under your care and we have the data, and we're going to hold back 25%. But you can earn it back. All right, how do you earn it back? You got to meet some standards. You got to meet some metrics. All right. So what are we talking about? This is where doctors, and I'm going to speak for outpatient only, prescribing practitioners, and I'm going to speak specifically to primary care doctors, okay? Because that's where we live in our brick and mortar office. And so I can't speak for specialists by firsthand knowledge, but for you as a primary care practitioner, primary care doctor, you have to meet certain metrics, and then you can have your money back that we withheld you. Not extra, not bonus, just the money that you used to get, but we're holding back now. What are those metrics like? Do all the 50-plus-year-old women who are under your care in our memberships, in our system as members of our insurance plan in your practice, among all the 50-plus-year-old women, do you have at least, again, I'm making up the number, 65, 68% of your women who are candidates for a mammogram, have they had mammogram screening in the last year? And for those who don't need it every year, you have to document and prove who those people are so that they don't get counted against you, all right? For all individuals 50 years and older, now 45 years and older, men or women, are they up to date with colon cancer screening? Are they 70%, 72% of all individuals over that age, have they had appropriate colon cancer screening based on their profile, okay? All 17 to 23-year-old women, what percent, have you met a metric of 53%, 58%, whatever, who have had screening for gonorrhea and chlamydia by urine testing, all right? All your pediatric individuals under the age of 18, under certain age bracket categories, what percentage have you met in all of them having had an annual well visit? Furthermore, diabetics, how many of your diabetic patients have met a criteria of their A1C, their 3-month blood sugar, being under a certain percent as a marker, a biomarker number in that year? Your hypertensives, do 74% more or over or under 74% of your hypertensive patients meet the criteria of whatever blood pressure number is the criteria? Let's call it 140/90. All right. Okay. And the list goes on and on. Now, what's the big deal? Here's a couple things. One is it is important for you to realize that practitioners have this financial incentive that they're trying to meet. No one's keeping track of all their numbers. No one's able to do that. That's what those third-party entities are for, these pseudo unions. They're helping all these doctors and practices keep track of that data. It's data mining in the end, okay? And I do believe it's with good intention, all right? A lot of these are, I'll say most, if not all of these are based on public health level, scale, population health level, good intentions for better health for our communities, our country, all right? Cancer screening, blood pressure management, diabetes management, et cetera. But the downside is, it is important to know that there is financial incentive to meet these metrics. And secondly, that is why some patients get so frustrated and don't understand why I walk in there to talk about my back pain, but they got to measure me every single freaking time. And they make me take this depression questionnaire every single freaking time. Like, why do I got to do that every time? It's so annoying. It takes time. It's another piece of paperwork, another form to fill out. And then I'm 17 years old with back pain. Why do they got to make me check this urine testing? What does that have to do with back pain? Are they checking me for drugs? No. Are they checking me for a urine infection? Maybe, maybe not. But the reason is they're checking you for gonorrhea and chlamydia. And if you ask that and found that out and you're thinking like, do they think my back pain's from gonorrhea and chlamydia? No, absolutely not. It has nothing to do with your back pain. But the reason they're doing that is for totally separate reasons. And when you have these multiple components vying for the attention of what's in not necessarily just even the practitioner, the doctor, nurse practitioner, whoever, but the office as a whole, okay, there's systems all in place to capture all these people, right? When they're in the office to do X, Y, and Z, depression questionnaire screening, gonorrhea, chlamydia testing, they want to take advantage of those moments to try to meet these metrics. And so it dilutes the experience of why you're there for, let's say, your back pain or your shoulder pain. And it's easy for a patient to feel like, am I just a number? They're not paying attention to why I'm here. They're like, they have alternative or ulterior interests, which is true to some degree, okay? So it leads us as patients and consumers of the system to feel more like a number. And truth be told, when we're talking about population health, we are a number, all right? That just sucks, but it's not necessarily bad in my opinion in value, but it's the way we feel, and that just sucks, all right? Now, so going back to the very original question, right? Don't doctors get paid for writing prescriptions? Not that I'm aware of, but they are financially incentivized and they're thinking about their financial issues from this other way, okay? And so then furthermore, if you are someone who has high blood pressure, if you're someone who does have diabetes, and it feels like doctors are trying to push prescriptions, all right? whatever happened? Hey, Mark, like whatever happened to lifestyle change? How come no one's ever talking to me about trying to improve my eating and exercise habits? Why is that not happening? Because that isn't going to move the numbers. All right. To get your A1C down, to get your blood pressure numbers down, it doesn't, who knows how long that's going to take for your eating and exercise habits to get started and to sustain. All right. And therefore, for the doctor's office to be able to see the results and be able to document that before the end of the calendar year. All right. God help you if you're in October and you have high blood pressure and you're on medication already, let's say, or let's say you're not on any medication, your blood pressure's been high for 3 years. They see your blood pressure still high. And then you've never really taken full action to change your eating and exercise habits, but you're more motivated than ever right now. All right. For whatever reason. And you're saying like, I know this and that, but I have a plan. Here it is. I'm laying out for you strategically. This is what I'm going to do. And I'm revved up. Let's go. And they're saying, no, here's a medication. And you're like, what happened? Like, how come you're not on my team? How come you're not supporting me? It's October, dude. They got to meet metrics by the end of the calendar year. Even if you execute those plans now, the chance of your blood pressure changing in the next 2 months, 3 months is pretty low. All right. It's statistically speaking, it's pretty low. And then they've got to be sure you come back before the end of the calendar year. Even if you make an appointment, the likelihood of you canceling that appointment or rescheduling it, something came up, you were sick, your family member's sick, you don't make the appointment, and then they can't document it. And then the last blood pressure they have on record is the high one, they're penalized. So they're doing everything they can within their power. That's the thing, within their control to try to get your blood pressure down because they're trying to meet metrics. All right. Now, if you've got a doctor who isn't so minded about that stuff, right? They're like more of an idealist and a purist. And they're like, yeah, man, I'm on the side of my patient. All right. And they don't feel, and they're not thinking about those voices and pressures in the middle of your visits. Awesome for you. All right. Now, whether you actually take those steps and execute those steps and lower your blood pressure or your A1C as a diabetic or whatever over the coming 6 months, year, 2 years or whatever, that's between you and your practitioner. And a lot of us, those things don't happen or they don't sustain. And then we don't actually ever, or we very much in a delayed fashion, if ever, do what we voice that we're going to do. But that's another story. All right. Your practitioner, our practitioners, they know that they can only control things to a certain degree, and they're financially penalized for not getting results. The insurance plans want to see change in their members so that there is, on a population level, less disease, less cost to them. Cancer screening, let's reduce cancer so that we're not having to pay for all that chemotherapy and radiation therapy and surgeries and blah, 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 which is big time, big bucks, right? But we can only make that happen by cancer screening, let's say, okay? Let's reduce the risk of heart disease with all the costs of caths and stents and bypasses and blah, blah, blah. But we got to start with getting people's blood pressure down, their weight down. The insurance plans are not coming after the actual users and patients and saying, you've got to stop smoking, you've got to stop blah, blah, blah. If you keep smoking, you're going to pay more for your plan. We've heard that in the news for years. Should people who partake in less healthy habits or meet metrics like have a high BMI or whatever, should they have to pay more for the insurance plans? I don't know where that's going, but insurance plans have never taken that step to say, yeah, we're going to execute some level of that. No, instead, they're penalizing and they're making the doctors be responsible for executing that behavior change, which is the holy grail of medicine. The holy grail of healthcare is behavior change, in my opinion. All right. No, that's for another time. They're making the doctors responsible for that. And then they're penalizing them if it doesn't happen. All right. They're believing, this is my interpretation, they're believing, likely, arguably so, that a doctor is going to be able to affect behavioral change more than they are, at least, to a patient. But the doctors are screwed and are in this kind of in between. They're put in a really hard position in the corner of the room. All right. So there you have it. There are financial incentives, but as far as I'm aware, they're not in the form of prescription writing. It might feel like they're just looking to write prescriptions, but it's not because they're paid prescription. They're paid for writing prescriptions. There are financial incentives for meeting metrics. And that, my friends, is one of the biggest reasons a lot of patients feel like they're a number and their visits are not prioritized to what their wants and needs are for that given visit, but towards other undefined and uncommunicated, poor, non-communicated activities that occur in any given office visit. So there you have it. That's the world as I see it.
just the way you like it.